Thank you, sir, for that. For those words. I think I continue to say that in the introduction because the last time when I was supposed to take up this talk, I said it's a professional suicide that I'm going to do. And probably after reading all these things, just slightly along those lines. And this is a product which has been launched, relaunched. But does it have a role? I'm not going to focus on the negatives of this. I'll just focus on the positives of this, where this molecule has got some evidence to a definite evidence. This is just the Rolling Stone gathers no more, but this has been the Rolling Stone of psychiatry for a pretty long period of time. As Sir said, it's a panacea for everything. But remember, lithium also used to be a panacea for everything, but it has got its indications later on. Now the topiramate, very sorry for that. The topiramate, whereas it actually gathered now, so that's the only thing I'm going to focus on. I'm not going to focus on anything else. Okay, just a brief introduction onto the molecule per se. This is analog of fructose. It's a monosaccharide. It's a sulfonate substituted monosaccharide. Discovered by two people. This is actually Bruce Marinoff. I was unable to get a photograph of Garocki and Joseph Garocki. These are the two people who have synthesized this. Of course, McNeil Pharmaceuticals was the Otto McNeil. They were the people who actually bought it. Its structural similarity to acetazolamide is the reason by which it was actually started as an anti-epileptic drug, or it was tested for anti-epileptic properties. Now, we know that they have to act on some channels to have anti-epileptic efficacy, and these channels might overlap with a lot of other disorders. That is why it might come in migraine, bipolar, and all of the things. It of course blocks the voltage-gated calcium channel and L-type calcium channel, but it's a sodium channel blockade which is much more clinically significant because that is what actually results in anti-epileptic property. The other things that are probably acted upon, GABA augmentation, the AMPA and kinase receptor augmentation, antagonism, are the other mechanisms. And of course we know that it is not just structurally similar to acetazolamide, it has got definite action on carbonic anhydrase. It is an inhibitor of carbonic anhydrase, and probably that is why we have to be careful about metabolic acidosis and renal stone formation in this case. Just to say where all those things are, the AMPA receptor and kinase receptor, the voltage-gated sodium channels, calcium channel, the L-type is not there in the pictures, are not highlighted that. The GABA, the synaptic terminal, but it also acts on GABA transamylase and also the GABA transporter. All these are sites of basically anti-epileptic efficacy. And how do they actually act? It's not a direct action. Again, it's a phosphorylation which is acted upon in these sites, and that actually leads to the channel being closed. Now, coming to brief kinetics, I have to dwell on all these because evidence is shaky in many areas, but absorption is a very rapid thing. That's a very good thing for us. It's not affected by food. Bioavailability is around 80%. Now, peak plasma concentration approximately in 2 hours, and it's a mean half-life of 21 days, and it reaches steady state plasma concentration by 4 days. 21 hours of peak plasma concentration by 4 days. Renal elimination is 70%, so it's a predominantly renal eliminated drug. But remember that you have to decrease its dose even in hepatic compromise, mechanism of which is not very clearly known. It is said to have very little interaction. These are the possible sites, but clinically it does not have much interaction with carbamazepine or valproate. Even though the product manufacturer says that with valproate there is a 14% decrease of topiramate concentration. But at the clinical level, you just really need not bother about the dosage and interactions. This is what I said, 42% dose reduction is needed in a renally impaired patient. Hepatically impaired, there is no actual guideline, but you have to go for a lower dose. Why it actually has got a decreased elimination in hepatic problems is not very clear. Now, definite evidence. Definite evidence is present in, as was mentioned, in focal and generalized tonic-clonic seizures. The specific syndrome is Lennox-Gastaut, which has maximum evidence. Most frequently prescribed and most evidence again in migraine. Now, the latest thing is in weight loss, where it is a combination of phentermine with topiramate. The phentermine-topiramate combination. Phentermine was there in the obesity market earlier as a molecule called fen-phen. That was fenfluramine-phentermine combination. Fenfluramine was subsequently withdrawn because of its high prevalence of cardiac abnormalities, especially persistent pulmonary hypertension and stuff like that. So, phentermine was in search for a buddy, if you want to say so. And the buddy turned out to be topiramate. And the phentermine-topiramate combination has got an FDA approval in obesity and weight gain. And topiramate per se, as a single drug, is now under trial for obesity. Now, off-label indications. This is where all the psychiatric indications come in. The first one, bipolar, I'm not going to talk about it. Alcoholism, antipsychotic induced weight gain, obsessive compulsive disorder as an add-on, post-traumatic stress disorder, the symptoms of borderline personality disorder, essential tremor, bulimia, and of course, your indication is coming in this in infancy, whereby children who have got hypoxic ischemic encephalopathy, it is given to prevent periventricular leucobilation. Now, the other things are idiopathic intracranial hypertension, cluster headache, pain. I'm going to just bypass that because anything and everything has been tried in it, and I'm not going to talk about it. Tourette syndrome is there. But again, the evidence there is on one study, and I completely left that out. The maximum evidence, and where it can definitely be prescribed, is still alcohol use disorders. There are 22 studies, 2 meta-analyses, 8 RCTs, and 6 open trials, which actually show that it is efficacious. And the most robust evidence comes from around 600 subjects who have undergone randomized double-blind placebo-controlled trials. And there are studies which tell you that even less than 100 milligrams of topiramate, the target was 75 milligrams in that study, is efficacious in alcohol, in relapse prevention. And 200 and 300 were the other doses which were actually tried. Now, what was the collated data say? Collated data was saying that it significantly decreased the drink days, decreased the drinks per drinking day, and the percentage of days where the patient was having a heavy drink. And also it increases the percentage of abstinent days. These were the targets which were found to be significant in the meta-analysis. Now, final conclusion of the meta-analysis was that it should be used as a first-line agent. And they've also said that low-dose topiramate is pretty okay. And if you take a specific subset of people who have got heavy drinking and have got a specific genotype, that is the glutamate receptor kinase 1, RS28324007, that is CA translocation. They have this specific genotype. Topiramate is a wonder drug for them. It can actually bring down significantly the heavy drinking in them. And there's a separate study in this year's Journal of Clinical Psychiatry which says the same thing. We have to target these people, and now we have actually shifted to pharmacogenomics of treating alcohol dependence. The pharmacogenomics applied strategy. In these people, topiramate is a definite wonder drug. Now, topiramate versus others. There are studies comparing topiramate with naltrexone and topiramate. One open study comparing topiramate with disulfiram. Topiramate with naltrexone, there are 3 studies, and one is a randomized study, but 2 others were pretty long studies, 2 naturalistic studies running up to 6 months, showing very clearly that topiramate was superior to naltrexone. The dosage used was just 200 milligrams. And the one open label study, an open label study always has its own limitations, and you can't draw any conclusion from this. It said that disulfiram was slightly superior. But leave that aside. What are the prescribers now telling? Prescribers are now telling that you actually should bring topiramate back. That is why Australians are saying that it's not registered and should be used by specialists, but their plea is that it should be registered and should be used for all by all in the case of alcohol dependence. These were other things, naltrexone and stuff like that. Important point in acamprosate is pretty good in a patient who has reached abstinence who want to continue in abstinence, not like other drugs. The second problem that I'll discuss is borderline personality disorder. We know how difficult it can be for all involved, including the therapist. The symptoms of borderline personality disorder. This is a meta-analysis or a review of all the randomized trials which came in the British Journal of Psychiatry in 2010, which said that topiramate is one of the drugs which you should definitely consider. Now, what does topiramate do? It acts on specific symptoms. If you take any drug and you try and analyze that in borderline personality disorder, we are not looking at the syndrome as a whole. We are looking at symptoms in part. And different drugs have got different mechanisms and different outcomes. And you read all the reviews, you will say which all drugs act on which all symptoms per se. But topiramate has got a significant decrease on interpersonal problems and impulsivity. This is both in males and females with borderline. And when you come to anger, there is a definite decrease of anger, and anger is decreased more in females than males. These are all the interesting findings that topiramate has. The associated psychopathology of borderline, the general other psychopathologies which might be present, including transient paranoid ideation, stuff like that, actually decreases. But anxiety, there is definite evidence to show that there is a decrease of anxiety if you give topiramate in borderline personality. This again as a single drug. Now, the other condition where it is being shown to be efficacious, there's a larger trial that is actually going on still on post-traumatic stress disorder. This is an earlier trial of the data which I am presenting. It showed that around 80% and above of PTSD patients, when prescribed topiramate, had improvement, and the improvement were in re-experiencing symptoms, flashbacks, intrusive memories, and nightmares of the trauma. Now, binge eating disorder, another indication where it is used as a single agent. All these are indications where these are not add-ons, these are single agents. Whether you talk about alcohol use disorders, borderline personality disorder, post-traumatic stress disorder, or binge eating disorder. Binge eating again, these are large studies on multiple drugs. This came in Obesity Journal, and it said that even including topiramate, the biggest problem with topiramate in most studies was that the attrition rate of topiramate, because the side effects, was huge. But in the case of binge eating disorder, there was not much of attrition rate when compared with other drugs. And topiramate and orlistat, when you compare with all other drugs, came out on top. And that was the drug which has been having enhanced weight loss. And this was there even in combination therapy with non-pharmacological agents like non-pharmacological methods like CBT. So topiramate is a definite go in binge eating disorder. Now, coming to slightly more dicey territory, topiramate as an add-on in schizophrenia. This was the first major study which came in as an add-on. This is the Upshur study. This is a much criticized study, but again I'll just show it as a data. This showed that not just the positive symptoms of schizophrenia, but also the negative symptoms and psychopathology decreased when topiramate was used as an add-on to an antipsychotic. And the clinical response, that is defined as greater than 20% reduction in PAN score, was higher in topiramate when compared to the controls. This study later was included into this meta-analysis, and I call it this is a quantitative literature review and meta-analysis. But the study was actually subsequently removed from this meta-analysis, and the data was presented based on the TON and the Muscatello studies. Basically because this was having a slightly higher response. You see that it shows that topiramate is a remarkable molecule when compared to the placebo. But even if you take that study off, the analysis concluded based on the 3 RCTs and the data that in clozapine augmentation, this had a definite trend to decrease positive symptoms. Negative symptoms is iffy, but positive symptoms there was a definite decrease. And of course, this secondary measure was actually weight reduction, which of course actually showed weight reduction. Now, the most recent is this one, Journal of Clinical Psychiatry in 2016, which was looking at on the schizophrenia spectrum, both in terms of the improvement of psychopathology and weight gain. But here, weight gain was probably the more important measure that they were looking at. It definitely showed that there is a decrease in general psychopathology, total positive and negative, but negative was just above the mark, probably not very convincing. But there was a definite decrease in weight gain and BMI, and this was pretty well tolerated. So this is a drug which can be considered in case of an antipsychotic weight gain. Now, resistant OCD, few studies, modest evidence. It just shows that topiramate has got a decrease in Vibox score around 32%, but when you compare with placebo, it's just 2.4%. And when it went into a larger study, this is a collated study of all the studies in OCD. This includes this one RCT, 2 open label studies, and several case reports. And when they were totally analyzed, it was found that they improved compulsions and not obsessions. So it has got some role in decreasing compulsions, especially as an add-on. Now, resistant major depressive disorder is only one study. This came in the year 2015, the recent study. This actually showed that, in a short-term study, 8-week study, augmentation of SSRI, it showed that topiramate definitely decreased depressed mood, suicidality, insomnia, agitation, and anxiety symptoms when given as an add-on drug. Migraine, we do encounter migraine. We will have to prescribe drugs for migraine. That is something which we can't actually just leave by. Migraine probably is ours more than anybody else's. And 40% of migraine is comorbid with depression. And migraine has got a 2.2 to 4 times higher risk of developing depression. And a first episode of migraine is higher by 2.8 to 3.5 times in a person who has depression. And our data, this is an unpublished data, this is by Dr. Askia Khalil, who did a thesis on migraine and bipolar. And she found that 38% of bipolars had migraine. So there is pretty much evidence to show that this is our area. And this is a wonder drug in migraine. There is no two words about it. Whatever dose you're targeting, even at 100 milligram, probably it's a very good drug. Just to show the prescribing status and prescribing method in migraine. But please remember that this is one area where you can definitely use it. Now coming to adverse events, greater than 10% only for paresthesia, anorexia, weight decrease, which is actually not an adverse event in many cases. Difficulty with memory, we'll come to that in later things. Taste perversion, upper respiratory tract infection, and also some amount of abdominal pain, nausea, diarrhea. Probably expected. These are the actual symptoms which are actually put in the psychotic spectrum by neurologists: confusion, psychomotor, slowing, decreased concentration, memory, speech or language problems. So there is not much evidence of topiramate-induced delusions and hallucinations. We look into the literature per se. It's a very, very iffy evidence. Psychiatric behavioral disturbances, depression, mood problems have been reported, but again, not much of it. Somnolence and fatigue are two other commonly reported side effects. But these are certain things which you have to be wary about. One is acute myopia and acute angle closure glaucoma. You be careful about these things. You may have to have consultation. If somebody comes with a visual disturbance, you have to look into it. The second thing is, of course, hyperammonemia may happen even without valproate, but very common in valproate prescription along with topiramate. Kidney stones, usually in combination with other carbonic anhydrase inhibitors or somebody on a ketogenic diet. This is actually a case by Dr. Dinesh Kumar. It's his case. Topiramate induced bilateral angle closure glaucoma. The patient actually improved significantly after stopping topiramate and giving targeted treatment. We have reported it in the Journal of Psychiatry sometime back. Now, where has it gathered? Finally, probably in alcoholism, definitely yes. borderline personality disorder, this is a drug you should definitely consider. Antipsychotic induced weight gain, very good option. Augmentation in schizophrenia, it's open for debate. Obsessive compulsive disorder, let's wait on that. Refractory depression, again, let's wait on that. Migraine, there is no point waiting, you can definitely prescribe it. Binge eating disorder, few cases, but again, it is a good drug. PTSD, in few cases, but still a very good drug. Cocaine addiction, one study, I have not put that study, it was just like today. It's a study which says it's a modest effect. Now, so the role has some role. So we prescribe very well. Prescribe is up to you, but definite evidence in alcohol dependence, weight gain issues and stuff like that. So probably we should reconsider this molecule, and probably it may have a definite role in alcohol use disorders. Thank you.
Thank you, Rajwar. It is a very brief, succinct, at the same time comprehensive presentation. In fact, why it became brief must have been because the studies have not been very convincing. The studies have been mostly, case report or open studies and so on and so forth, which we try to mention. And of course, the effort is commendable that we had tried to find out where we can think of this molecule in our professional life. To set the ball rolling, I mean, the certain indications are very clear, but what we have to look at into is like one who said where as an add-on drug to clozapine, the problem is that there are reports where topiramate causes quite a bit of confusion, and this confusion increases when it's used as an add-on drug to clozapine. So that, of course, is not on a sufficient sound ground. Perhaps, as you rightly mentioned, its place in borderline disorders and alcoholism is to be really looked into. After all, we want our psychiatric armamentarium get strengthened more and more, especially in these two areas where management of alcoholism is indeed frustrating for clinicians, because the kind of relapses they have in spite of all the deterrent drug like disulfiram and the promoting drug which could be used even when the person is using alcohol. So the management of alcoholism is indeed makes us more and more desperate in our endeavor, and perhaps that is where we need. The other one, of course, is management of borderline disorder. Like they are very difficult to be managed. Perhaps that's why we all say that we have to try even DBT along with all kinds of drugs, right from anticonvulsants and off late SSRIs and so on and so forth. I'm sure Dr. Rathmohan's presentation have really aroused cues, questions and curiosities. I invite every one of you, from the junior most postgraduates to the senior most, to contribute.
Regarding the point that you mentioned about topiramate being used in clozapine, studies actually showed very little efficacy very few people develop confusion. And very few people don't. It's a very surprising thing. So it's expected, and one of the major problems with topiramate is actually confusion with LED.
I want to share a few of my experience with topiramate. One of the one of the first case, and he's still one of my patients who still follows up with me. He's an extremely obese person, he weighs 114 or something. He was on a treatment with psychiatrist at Perindalmanda. And the combination was clozapine and the topiramate for weight reduction. He was having persistent confusion stage, and it was found he was having hypoglycemia continuously. And if you read the literature, I think he must have mentioned topiramate came out as an anti-diabetic. It has, and then later on it was changed over to anti-epileptic. I think there is a risk. He's just thinking about it as an anti-epileptic add-on. This patient was an hypoglycemic. He stopped the drug, and then he became he maintained his sugar level, and he still follows up with me because it was detected. The second thing was regarding that I think. I'll just tell the comment, and I started this topiramate on this person. The next day, this student was a Kannadiya. What man, your drug has made him blind? I'm shocked. He thought, we have not seen such case with topiramate. He's totally blind the next day. And then we referred to with the literature, and we found topiramate does cause this problem. And if you persist with continuing with the topiramate, permanent loss of vision.
I actually went through the literature. The mechanism is not at all how it actually has an anti-diabetic or OHA property. The mechanism is not at all.
Then I should be case reporting that. Because
no, the mechanism is not at all. That's why I said we probably will have to revisit that. Actually there are reports per se that slight sugar variation, but that's not talk about significant sugar variation. Anti-diabetic per se, the trials are very short and it was actually short. But the first trial actually was actually the AED trial. Because when it came out, the mechanism and the molecular structure, it was something like acetylcholine. So it actually went straight into anti-epileptic.
Dinesh, was that patient was diabetic initially, previously before starting topiramate?
He was.
Topiramate can interact with the metformin, and it can definitely reduce the blood sugar.
He's obese. He's a metabolic syndrome.
If that patient was already on metformin,
yes,
that can definitely interact with the topiramate,
there is a risk
and that can increase the confusion, and that can take the patient to hypoglycemia.
You should keep in mind the hypoglycemia if you are adding topiramate for weight reduction.
But actually, topiramate is contraindicated in patients taking metformin.
It's not a primary thing.
Probably that could be.
Anti-diabetic drug, if you add up, increase.
That's what. Some things regarding the studies in alcohol. No? Do we have any studies comparing topiramate with any other anti-craving agents like baclofen or acamprosate or even disulfiram?
Disulfiram is no good in this.
But I think the other comparison studies, acamprosate or baclofen, do we have any sort of such studies?
There are three studies with naltrexone and one study with disulfiram.
But actual comparison that anti-craving studies are, I think it is less. Like with the acamprosate.
I mentioned this. The comparison with naltrexone. There is only one double-blind randomized study. That was a short-term study, 12 weeks, but that's not it. Two other studies were naturalistic studies, but that actually showed naltrexone is likely.
What we need is actually some gold standard drugs which are already there, no? like disulfiram. So there should be some comparison.
If you get the Western state, they will tell you that disulfiram is not a personality. Even though for us, we know what it is.
No, some vested interest, I think it is there, because the comparison drug what they are choosing is not the one that we are commonly using.
Probably the action, I think, is more of an anti-craving. You are talking about craving. Anti-craving drug rather than
actually, I can definitely say that it's better than dosing disulfiram. If you look at the long-term action of dosing beta hydroxylase, it actually should be an anti-craving.
And another thought what he has said that topiramate we cannot use in alcohols who have got some moderate to severe liver impairment. So that case also you cannot use topiramate.
That's a very big problem because the mechanism by which it interacts with the liver is also not clear. It is said that you can't use at a high dose because it is significantly less excreted in a patient who has got liver problems. But mechanism is not clear.
So generally what we can do that we can give topiramate only to some moderate drinkers. For a severe, mild, moderate alcoholic state. That's
One more comment. One of my friend neurologist in Vendamana, he used to say, especially children, when they are going to school, they have difficulty in this memory issue, word finding difficulty. He always does. So even when you mentioned it's 12 years, about 12 years they have mentioned. It should not be used in people below 12 years because it can definitely interfere with their studies and they find
and topiramate is coming as a promising agent for OCD in bipolar disorder patients because, and a recent study which I went through 2 days back in 2014 they have published in Journal of Sleep Disorders. They have augmented, it's a double-blind placebo control trial in which topiramate they have added for a combination of lithium and olanzapine. They found that there is significant improvement is there with topiramate group compared to placebo. And after that I had gone through it before also. Then I had tried for 2 or 3 patients. One patient with bipolar disorder in remission, with migraine and with OCD. Patient had with 100 mg topiramate there was significant improvement. When they stopped the drugs by themselves and they came back to me presenting with the OCD symptoms again. Another patient was bipolar with OCD. Patient responded well to topiramate.
Actually, there are 2 studies in bipolar. One is bipolar weight gain and the other is bipolar OCD. Bipolar weight gain is a definite negative study. It actually worsened the bipolar in their patient. Surprisingly, bipolar OCD, nothing happened, the patient improved.
Interestingly enough, years ago it was promoted for bipolar, but then
it was Patricia Saplis who was actually behind this for a pretty long period of time.
So the problem with the sodium alcohol again, many patients can develop hyperammonia. Hyperammonia syndrome. That is the main problem if we combine topiramate with sodium alcohol.
in combination with
Yes.
Yeah, but this is like
That problem is more.
pregnancy status.
it's a contribution. Category C onto D.
your liver dysfunction, renal dysfunction is known to cause renal failure, sometimes kidney stones.
Carbonic analysis. Carbonic analysis.
Even they are advising some diet modification also that people they should take enough carbohydrate. If they are taking less carbohydrate and more protein diet, then there is a chance for metabolic acidosis.
A seizure patient on a ketogenic diet should never be prescribed coffee.
May not be that
Out of topic, my doubt. Suppose we are saying we have to take migraine as ours. So pregnant woman, what's the drug of choice if you have topiramate not even propranolol?
Wow, which is a category B drug?
It's my question.
Category B.
Toss.
You just toss it and decide. Definitely not relevant.
Ajay? So,